You understand? I will not use it in these two cases. Ruptures I will not use it, of course. Aneurysms I will not use it. Right? So this is all about IABP. Okay. Apart from this, there are two more SS devices that are there in the market, which used very rarely, but maybe HM may be using it at times. It's called impeller. It's called impeller and ECMO. We know artillery. Okay, an impeller device is an expensive device, but that is a kind of catheter that goes over there and rotates and gives more cardiac output on that area. Okay? So impeller device and main artery. Right? So what we've understood from cardiogenic shock is to understand first how severe the disease can be. How severe the disease can be. Don't treat a cardiac failure patient coming into the. What happens for you is when you're working in intensive care, you have not seen those patients in the wards. You have not seen those patients in the OPD. For you, everything is simple. No, they are critical. I understand. They're all critical. You can't consider a patient in the ICU to be okay. He can't be okay. They are more severe and more critical than those patients who are coming to the ward. You are understanding? That is why you have to assess them very well. So, what is cardiogenic shock? After all, it's all gone into clinical features. It's all gone into vitals. It's all gone into understanding what you're doing. Are you understanding? If somebody asks you, am I going to intubate this patient? It's a clinical call. Am I going to intubate him? Yes, I can. Why? By intubation, what am I going to achieve? I'm going to achieve a complete loss, a complete improvement of his work of breathing. And all the blood that is going into the diaphragm is now going to go to improve the circulation of the vital organs. If I take away the respiratory system in my hand and I paralyze this patient, nicely sedate him, put him on the ventilator and take off his work of breathing, what am I going to do? I am going to ensure that this patient gets good, some amount of blood that he was not getting going to his vital organs. So I will think, oh, let me intubate all my patients. That's not the scene at that moment. I would want to think this way also, that if I intubate, there is a possibility I will increase my auto-PEEP phenomenon. I will probably cause more amount of issues. This patient might have been a respiratory failure patient. I might cause other issues. Hypotension will become a vicious cycle. So I can't say a particular treatment is supposed to be used in cardiac shock. It is all a matter of judgment. For example, if a patient on top, you want to decide you want to give dobutamine. I don't know. Maybe look at the heart, look at the cardiac output. You want to give dobutamine, maybe you can give it now and see what happens. You may not do it, but I will see what is going to happen. I cannot tell you now that if I give dobutamine to that guy, he will die. I can't tell you that. See, you understand. His heart rate is 100, his blood pressure is 130. You may want to improve his cardiac output. Do it and see what happens. It's titrable, no? You are giving it, it will come out. But so as a doctor, you should understand that I have to be there when I'm doing something that I don't know what's going to happen. You understand me? I can't say I'm going to give dobutamine, that's a treatment for it. So you may want to start dobutamine, start it. Who's telling you to stop it? I will say yes. To try it and see what happens. Are you understanding? But will I start milrinone? No. He's a renal failure patient. I don't want to start milrinone. I can't titrate it. If I do something, it will go wrong only. For hours and he will go down. Why is this patient on pressure support? Doesn't make sense. 10 pressure support and 6 of PEEP. So that time he had got tired. Now he's not tired anymore. You understand? So we need more of PEEP. PEEP should be higher and higher and higher and higher. What you could have done here? You could have tried NTC in the night, isn't it? NTC could have helped him. We don't know. It would improve his cardiac output. The entire problem is EF is low. He is a clear case of what? What is he?
Heart failure with reduced
ejection fraction. First of all, you're right. He is a heart failure with reduced ejection fraction. Forrester classification?
Wet and cold. Wet and cold.
He's not wet. He's not cold. Is he cold? He's warm. He's not cold. His cavity feels okay. His nose is cold.
But he has
He's warm and wet.
Warm and wet.
He's warm and wet. So he's class 3. So his chances of dying are 20-25%. Right? Of course, I'm not looking at the renal failure part of it. Now you look at it now. Look at his severity. His cavity fill was okay. His heart rate, shock index was very bad. His lactates were elevated. He had this disorientation. So he goes to the, not the moderate category, into the severe category of heart failure here if you look at it. Because he's got major other things that are coming in. Classification wise is class 3.
Class 2 is warm and wet.
He was?
Warm and wet is class 2.
Warm and wet.
Class 2.
So he's warm and wet. So if he's warm and wet, then it comes class 2.
9%.
Yeah. So that's why I do everything on him. You got the point. But that doesn't mean he will go from warm and wet to getting better. He may go back to cold and dry. So you need to look at that. In fact, now because of CRRT on the background, is a very high chance of having all kind of issues here. You know, he may get extremely diuresed. See, in his case, what was happening is intravascular. When we did the IVC, we are expecting the IVC to be actually enlarged. But what is happening here? It is collapsing. The IVC is collapsing here. Who says IVC is collapsing? Who was there with the estimator doing the echo? When I was doing the echo. IVC is collapsing. RV is down, but our cardiac left ventricle is also down. So in this case, can I just diurese blindly? I can't. Can I just diurese blindly? I can't. I need something that I can titrate. How can I titrate? CRRT. Are you understanding? I cannot titrate dialysis. नहीं होगा मेरे से titrate because 8 hours के बाद I don't want to do 6 hours. I don't want to do. I can titrate this. I can titrate this system here. You got the point, So if he suddenly gets breathless, I will increase my UF for a while. If he doesn't get breathless, I will reduce it for a while. And slowly take him off the entire system. I don't want electrolyte abnormalities because I know his heart functions are low. But if I have 30, he goes down, there's going to be a problem. That's why I repeat electrolytes again and again. I don't want the electrolytes to be high. So anything that drops the arrhythmia, anything that drops the output, I want to avoid that. And congestion is one of the biggest things that does that. So I'm trying to decongest him. Are you understanding? Trying to get off the acidosis, trying to decongest him. Clear? This is about cardiogenic shock. Any doubts on this?